Hi everyone, welcome to ResearchMD.com. Another great presentation today. Today we're going to teach you about a very important topic, Pheochromocytoma. Before we go into our topic, I'm going to introduce myself, Dr. Pramil, Cheriyath. I'm a practicing physician in the United States, Program Director, Internal Medicine Residency, Translational Residency, and I teach medical students on a regular basis and Associate Professor of Medicine, two large medical schools in the United States. So why should we talk about Pheochromocytoma? The reason for that, the blood pressure, right? And when you have somebody with a high blood pressure, let's say some patient come to the emergency room evaluating for hypertension, right? The first thing your mind is like, does this patient have pheochromocytoma? Usually we call this hypertensive emergency or hypertensive crisis. So it's very, very important to know the pathophysiology, the symptoms of pheochromocytoma, how to diagnose it, and all of that, how to treat it is very important to know. So we're going to teach you all about it today, okay? So again, the topic is pheochromocytoma. The first thing we have to do is we have to define what is pheochromocytoma. If you look at it, it's a non-cancerous tumor arising from the adrenal gland, resulting excess secretion of epinephrine and norepinephrine. Okay. Now that's a broad definition. If you look at it, is all is non-cancerous? Apparently, is not. 5 to 10% could be cancerous tumor also, metastatic. Remember that. Okay. And the next question: does it all come from adrenal gland? Not really. Only 80% come from the adrenal gland. Remember that. 20% come from chest, abdomen, and pelvis, my friend. Okay, so just a little bit anomaly in our definition, but it's good to know. Mainly, right? 80 to like majority of the time, it's an 80% coming from adrenal medulla. 90% of the time is non-cancerous. And there's increased secretion of epinephrine and norepinephrine. Everybody got that? Now, let's look at the epidemiology. 1% of all persons with hypertension is very low incidence, and then usually in the third and the fifth decade, 10% may be cancer, which we already talked about it, right? Now, etiology, there's two types. One is going to be familial, around 30%, and the other one is like sporadic, which we don't know what causing. Some of the conditions like associated with the, we need to know, one is like Men's syndrome 2A and 2B, and then neurofibromatosis type 1, and then one Hippel-Lindau disease, okay? So clinical features very important. There's a good mnemonic, 5P. The first one is P, you can stand for pressure, okay? And what is the pressure? Like hypertension, right? Very common finding. And then next to the P is what? Palpitation. So, let's say next P is pain, headache. Usually I have like very severe headache in these people. And the next P for palpitations, okay? And the next P is for like perspiration. There's a lot of sweating. And then the last P is for pallor. So remember, pressure, pain, palpitation, perspiration, and pallor. So all these things, like I put in a mnemonic, we have to understand. And then there's like a triad of symptoms. That's why the three thing, triad, which one? Headache, palpitation, and perspiration. That's the main triad of symptoms. So we need to know that. Now, 60% of the people can also have fever. Why is that? And this catecholamine, we already said, epinephrine, norepinephrine, it can act and they can release IL-6, and that inflammation itself produces the fever. So just remember, like 60% of them could present with the fever, okay? Now we talk about the presentation. Let's go into a little bit of pathophysiology. How does it work so we can understand the things better. Now we're just going to look into the pathophysiology. Let's dig deep in what's exactly happening in the pathophysiology, okay? Familiar or sporadic? We already said 30% is familiar, remember? And then you got dysfunction of various tumor suppressor genes. There is oncogene proteins involved. What does it do? Uncontrolled proliferation of the chromaffin cells of the adrenal medulla. Okay, that produces adenoma formation, which leads to increased catecholamine, epinephrine, and norepinephrine. Okay, remember that. Increased production of catecholamines, epinephrine, norepinephrine, main thing is involved. It could be episodic hyperactivity of the sympathetic system, and there is hyperstimulation of G protein coupled receptor. So the two categories we need to know. When we look about episodic hyperactivity of sympathetic system, let's look at the first one, vasoconstriction of the peripheral blood vessel. That is the one the patient is going to have pallor because decreased blood, right? So sustained paroxysmal hypertension you can have, and activation of neural pain pathways, so the headache in the brain, we already talked about one of the P's. Okay, now there's hyperstimulation of adrenergic receptors in the cardiac myocyte. That's where like arrhythmia, tachycardia is very common. It can also lead into cardiomyopathy. Okay, so palpitation, tachycardia, palpitation, cardiomyopathy because the cardiomyocyte's involvement right there. And then secretion from the eccrine sweat glands. We already talked about perspiration or diaphoresis, the P's, right? And then you can have panic, tremor, and anxiety also. But then when you look at the hyperstimulation of G protein coupled receptor, you got increased lipolysis, increased glycogenolysis, and increased gluconeogenesis. So what's going to happen? You're going to have high blood glucose, right? Okay. When you high blood glucose and then hyperglycemia, you can have weight loss and fatigue because of all this mechanism happening over here. Okay. Now, one thing we also want to understand, just look at how in the adrenal medulla, how is norepinephrine and epinephrine is produced. Start with the tyrosine and then convert into DOPA, then there's dopamine and norepinephrine and epinephrine. Okay, the thing we need to understand is dopamine secreting tumors in the adrenal medulla is very, very rare, only sporadic. As you may see some case report, mainly what? Epinephrine and norepinephrine. Remember that. Now, if it is epinephrine, and then usually because of it also activate beta 2 receptor, usually it's like paroxysmal hypertension. Okay, if it is norepinephrine is more, there's going to be sustained hypertension. So that's the way we can kind of remember. Okay, norepinephrine, there's sustained hypertension. When you talk about the epinephrine, this is paroxysmal hypertension. I want you to remember that. Okay, now how do you come to a diagnosis? That's our next step. Okay, first thing you do, initial test is plasma free metanephrines you do, and then confirmatory test you do 24-hour urine fractionated metanephrine. That's a confirmatory test. Once you do that, after confirmation, then you have to look at the CT scan of the adrenal gland. You can do CT or you can do an MRI. And then, let's say if you see a solitary lesion, then you can go into surgery and take it out and repeat biochemistry after 6 weeks. Let's say your suspicions were metastatic, like it's all over, then you have to do the debulking procedure to remove all the tumors, okay? Now, let's say the CT scan come back negative, right? We still do like more tests. So first thing you do like clonidine suppression test. So what is that? You give the patient like 0.3 milligram of clonidine, and then you measure the norepinephrine levels in the blood, and then usually you should see, I mean, it should be like less than 40% from the baseline. Okay, so if it is more than that, then you have to think about it's a positive test. You can also MIG SPECT and CT PET scan kind of light it up the lesion because it's 20% it could be like anywhere. You can see that. And then if negative, then you start the pharmacological symptomatic treatment to control the symptoms. Okay, remember that. So how do we treat it? That's our next question, right? Treatment, it could be operative or non-operative treatment, okay? First, when you talk about operative, couple of drugs we have to give. One is you have to give like, prior to surgery, you give phenoxybenzamine, okay? So it blocks the alpha blocker. It's an alpha blocker pretty much. So epinephrine and norepinephrine will not combine with it, okay? Then you also give beta blocker, and then you come to the surgery. Otherwise, you can have disastrous results on post actions and all that. Remember the two drugs you have to give, phenoxybenzamine and beta blocker. Everybody got that? Then you do the surgery, you're done. Now, let's say if it's non-operative, you just give phenoxybenzamine and to control the symptoms, okay? Now, malignant pheochromocytoma, you can use MIBG, which is similar to norepinephrine, and then it goes to the pheochromocytoma cells, and it acts like norepinephrine, binds to it, you combine with iodine and can destroy the cancerous cells, okay? That's the treatment. It's very, kind of like more, precise treatment is available. So let's summarize summarize, let's go back and take a look at it. What are the key points we talk about? I hope everybody can see in our whiteboard very clearly written. Again, I always say this is an advantage of using a whiteboard, right? We talk about the definition. I mean, you need to know 80%, even though it's a adrenal medulla, we have 80% only coming from 20% different sources right here. And then association with the other endocrine tumors like von Hippel-Lindau, neurofibromatosis. Sometimes it's kind of, you have to look for the neurofibromatosis lesions on the body. And then remember the 5 P's. Okay, the triad is like headache, palpitation, and perspiration, very, very important. Also fever 60% of the time. And then we know the pathophysiology, there's increased catecholamine, epinephrine, norepinephrine. Remember the production of norepinephrine, tyrosine, dopamine, norepinephrine is finally converted to epinephrine, and there's metanephrine, and the other one is called norepinephrine. Now remember, if it is only like epinephrine, you can have paroxysmal hypertension. If it is more norepinephrine related tumor, you can have sustained hypertension. Then we know all this episodic hyperactivity of sympathetic system. Mainly remember effect on the heart, that's why tachycardia, palpitation, cardiomyopathy, activation of neuronal pathway that causes the fever. Remember hyperglycemia. Okay, remember the action of increased secretion from the accretion gland. All the symptoms, if you look at it, you should relate it to what are the symptoms. Why is it causing the symptoms important, my friends? Okay. Now, remember, initial test is you do plasma-free metanephrine, confirmatory urine fractionated for 24-hour urine fraction metanephrine, and then you followed by CT scan, and then role of clonidine suppression test we need to know, and then treatment is, remember, the operative and non-operative treatment. Thanks so much for watching, my friends. We'll be back with another presentation soon. Please study hard. Very, very important topic. God bless you all.